thank you, Anne, and thank you, Emma, for that really wonderful and very powerful story, very thoughtful as well, actually. And so I'm a gastroenterologist. I work in Edinburgh, both at the hospital there, looking after a large clinic of people with inflammatory bowel disease, many of whom I've looked after for the last 20 years, and I hope to look after for many more years, but also at the university researching into the causes and the consequences of these chronic illnesses. And I think Emma has really illustrated the chronic and debilitating nature of inflammatory bowel disease. So I'm going to give just a little bit of overview about IBD, the impact on the individual, the impact globally, touching on who gets IBD and why, and some practical implications for today to set the scene for the rest of the conversation. So as a gastroenterologist, we're interested in the gut, and there are many things occurring within the gut that are really central to many illnesses. And when we start to zoom in on this, we can see that we have this layer of epithelial cells across the whole of our gut that separate these billions of bacteria from our immune system. And it's within inflammatory bowel disease that this seems to go awry. So we're talking about Crohn's disease and ulcerative colitis. Emma's talked about ulcerative colitis, which accounts for just over half, and Crohn's disease, which is about 40%. So this chronic bowel inflammation where there is a dysregulated mucosal immune system, an altered microbiome, which we call a dysbiosis, and very powerful environmental and genetic drivers. Emma's described the sort of relapsing and remitting and unpredictable nature. For some people, these illnesses progress over time, and we see that very much with Crohn's disease, and a need for, in most people, chronic, regular medication to maintain good health, and all too frequently, surgical intervention. And where we're at right now in 2023 is we have many unanswered questions and really still an urgent unmet need. So for the individual, we see physical aspects, pain, diarrhea, often with blood, often with urgency, sometimes with incontinence. We see an illness that affects not just the gut, but the joints, the skin, the mouth, the eyes, and the brain. We see systemic illness, night sweats, fevers, sickness, unable to eat, weight loss. We see a very profound psychological component, from fatigue to mental exhaustion, anxiety, and depression. We know there are long-term complications of the disease. It might be hospitalizations for flare, like Emma described. It might be surgical interventions where portions of the intestines are removed, often with a stoma formed where the intestines are exteriorized and the contents into a bag on the skin. But it's the impact on everyday life that Emma's brought life to. So it might be more time in the bathroom, impact on studies and work, including absence and choice of job, relationships, sex life, family planning, pregnancy, food choices, restricted to manage or avoid a flare. So who gets IBD and why? Well, the answer is anyone can get IBD. We typically see it in young people, but it can occur at any age, roughly equal male and female split. And we know when you take into account all other factors like environment and geography, it affects people of all ethnicities in all parts of the world. And this is something that we should take into consideration. So first described in the UK and North America as Crohn's disease at the first part of the 20th century, we saw the rate going up and up and up as the Western world industrialized, and really something that's now a very global phenomenon, which I can show you perhaps very neatly here, which depicts the 4 stages of the epidemiology of inflammatory bowel disease. And where we are in Denmark and in the United Kingdom, we're at this phase, where actually the incidence, the number of people that get IBD is roughly stable and has been for probably about a decade. But because we diagnose people when they are young, and because thankfully there is no obvious excess mortality, or if there is, it's very, very limited, the prevalence is going up and up. And we've looked at this in our population in Edinburgh, in the Scottish population. We calculated 5 years ago that 1 in every 125 people are currently living with inflammatory bowel disease. And we know that by 2028, that will have exceeded 1%. So that's twice as common as diabetes, type 1 diabetes. This is a big problem. And this very much mirrors what we've seen from Tina's data here in Denmark and elsewhere. But if we really think globally, and where the large number of people are going to be in the world, we can look at this acceleration phase that's occurring in huge populations like the Indian subcontinent and China. And we can look even more to the African continent, look at the big populations like you see in Egypt and Ethiopia and Sudan and in Nigeria. And if you look out to see where the population of the world is going to be in the next 50 to 100 years, it's not Europe. The European population actually shrinks. The Asian population grows a bit but then stays stable. But the growth in Africa. So this is a really important global issue. And if we can understand causes now and start to get to prevention, then actually we can offset a world of misery, quite literally, moving forwards. We recognize, I think, inflammatory bowel disease as an illness of modern living. The clearest epidemiological signal is urbanization. And if you look at the UN data, 2007 was the pivot point where the number of people living in urban populations exceeded the number of people living in rural populations worldwide for the first time. And that trend is only going in one direction. And so if we think about what causes IBD, we have environmental shifts that are very pronounced. We have a genetic background that Carl's going to talk to a bit more soon, and we have this altered microbiome, which appears to mediate what's happening. So you have modern living, the impact that I'll talk about in a minute, impacting the gut microbiome, and this genetic background that in part has been shaped by dealing with pathogens and plagues over millennia of human history. Not going to talk about the microbiome, but this is a really interesting area. It's a massive area for growth, for trying to work out therapeutic agents that you can use to target and reset the microbiome. And there's a lot that we need to unpack and unpick there. But the environment that we live in is something that clearly has changed a lot in the last 100, 200 years. Everything from diet to industrial pollution, food additives, hygiene, antibiotics, surgery, smoking, stress, exercise, sunlight exposure. And one of the things I've been very interested in, and there's a big interest here, is looking at the dietary components in IBD, about what causes IBD, and also looking then to see if dietary factors influence the course of the disease moving forwards. And one of the commonest questions that patients come to the clinic with when they ask me is, "Doctor, what should I eat? What should I do?" Because people know that what they eat has an impact on their illness themselves. And these are some of the factors that we now have really quite good evidence for around the onset of IBD. But it's really important to note that many people eat a very, very good diet and get IBD regardless. So it's just part of actually a very complicated puzzle. And working with very large data sets where we can control for multiple other factors, we can start to piece this puzzle together. From a clinical perspective, with a patient in front of us, particularly a newly diagnosed patient today, with our toolkit, what we're trying to do is actually get as close to healing as possible. And I put this up to show you that this is a twofold approach. First, if you go from bottom up, it's the conventional medical approach to heal the inflammatory process in the gut. But just as importantly, we recognize the psychosocial issues. So we're also trying to get tight control of the psychological issues so that we can have a holistic viewpoint to how we improve patients. So yes, we want to treat the symptoms. Yes, we want to control the gut inflammation. We want to minimize steroid exposure. And Emma gave a very vivid example of what patients will experience there. We want to keep our patient out of hospital. We want to prevent the disease from progressing. We want to decrease surgery and stoma formation and minimize the complications from our drug and disease and try and get people back to a normal quality of life with minimal disability present. And thankfully now, we have a really fantastic drug toolkit. And if you look at this timeline, it's very concentrated into recent years. There is a great shift happening, and in the clinic, I see the impact of these new medicines making a really big difference. And many of these new medicines have come from the big, careful work that's been going on through immunological studies, through genetic studies, through big, well-powered epidemiological studies that are really starting to bear fruit. So I'm going to leave you with the sort of unmet need of where we are at and the things that we really need to try and do. We must continue to raise awareness for patients wherever they are. We need to ensure equity of care for people wherever they are globally. We need to do better treatment-wise, and this is in multiple domains with newer therapies, better access to therapies, combinations of therapies, dietary, microbial therapies, etc. And there's some really interesting work going on in multiple strands here. We need better monitoring systems for patients. We need to be able to work out how we can stratify our patients so we can deliver personalized or precision medicine depending to get the right drug to the right person at the right time. The holistic remission piece I talked about. And then finally, this big picture that places like Predict here in Copenhagen, with the incredible work that Tina and her team have done to deliver on, is can we get close enough to the causes of these diseases to really actually look at how we can prevent them? And that would be amazing, not just for the people living in Denmark and in the UK, but for the world's population. And I think we have a real imperative and a mission to be able to achieve this. And thank you for your attention, because I think this is a great opportunity to help spread that mission. Thank you.